Hey everyone, and welcome to this explainer. Look, if you're a resident or a young doctor stepping into the intensive care unit for the very first time, you know exactly what I'm talking about when I say the ICU can feel like an entirely different world. Between the constantly beeping monitors, the massive complex machines, and of course the critically ill patients, it is incredibly easy to feel overwhelmed. But here's the secret to not just surviving, but actually thriving in the ICU. It's not about memorizing every single obscure detail on day one. No. It's about mastering a highly structured, systematic approach to patient care. So today, we're going to build your essential ICU survival toolkit together. All right, let's dive right in.
So here's our game plan for today. We'll start with a quick welcome to the ICU, move right into daily care and the fast hugs checklist, demystify mechanical ventilation, break down hemodynamics and vasoactive drugs, and finally, we'll tackle surviving sepsis and shock.
Starting off with Section 1. Welcome to the ICU, the basics of critical care. Now, you know the ICU is a really unique environment. You've got one-to-one nursing, plus this highly advanced continuous monitoring. But despite the incredibly high stakes, I want you to consider this quote from Jean-Louis Vincent, who is an absolute giant in the field of critical care. He says, regardless of the underlying cause of the illness, the provision of meticulous supportive care is essential to the management of any critically ill patient. And that's absolutely crucial to remember. Your primary role as a doctor here isn't always finding some magical cure. Often, it's literally just providing that basic, meticulous supportive care to maintain homeostasis while the patient's own body heals. Moving on to Section 2, daily care and fast hugs. So, to actually provide that meticulous care we just talked about, we rely heavily on daily checklists. But before we get to our main one, let's quickly cover the concept of a care bundle. A care bundle is basically a small, straightforward set of evidence-based practices, usually around 3 to 5 things. And the really important part here is the all-or-none rule. Doing just 1 or 2 of the elements? Yeah, that doesn't cut it. They have to be performed collectively and reliably to actually move the needle and significantly improve patient outcomes.
Which brings us to the ultimate ICU checklist. It's called Fast Hugs in Bed, Please. And yes, I know, the acronym is ridiculously long, but trust me, it works. Let's break down the first chunk. F is for fluid therapy and early feeding. A is for analgesia, antiemetics, and ADT, tetanus boosters. S is a really big one, sedation assessment and conducting a spontaneous breathing trial to see if we can finally get them off the ventilator. T stands for thromboprophylaxis to prevent those deadly clots, and H is for head-up position, specifically elevating the head of the bed to 30 degrees, which is huge for preventing ventilator-associated pneumonia.
Okay, continuing right down the list. U stands for ulcer prophylaxis to keep stress ulcers at bay. G is for glucose control because critical illness just completely wreaks havoc on blood sugar levels. S reminds us of meticulous skin and eye care plus regular suctioning. Now, I is super important. Indwelling catheter review. Basically, ask yourself, do they really still need that central line or that Foley? Because if they don't, pull it. And N is for checking the nasogastric tube position.
Finally, let's finish out the bed, please portion of the checklist. B is for bowel care. E is for environment, meaning managing the room temperature and surroundings, which is absolutely vital for preventing ICU delirium. D is for de-escalation, basically stopping antibiotics or any treatments that just aren't needed anymore. And P stands for psychosocial support. The ICU is incredibly traumatic for patients, for their families, and frankly, for the staff too. Recognizing and managing that human element is just as vital as staring at the monitors.
Let's jump into Section 3, mechanical ventilation basics. All right, so you've got your daily checklist down. Now let's tackle the scariest machine in the room, the ventilator. I know it looks like a literal spaceship console, but we can totally break it down. First things first, we have to separate 2 very distinct physiological concepts. Oxygenation is exactly what it sounds like. It's transferring oxygen from the air into the blood. Ventilation, on the other hand, is the clearance mechanism. It's transferring CO2 from the blood into the alveoli and out of the body. Whenever a patient is failing respiratory-wise, you always have to ask yourself, are they failing to oxygenate? Are they failing to ventilate? Or is it both? Think about the basic mechanics of a breath for a second. Normal human breathing is a negative pressure phenomenon. Your diaphragm drops down, and it creates a vacuum that naturally pulls air in. Mechanical ventilation is the exact opposite. It is positive pressure ventilation. The machine is literally pushing and forcing gas into the lungs. So the end result is the same, gas exchange, but the physical mechanics are completely inverted.
Now, when we actually go to set up the ventilator, there are 2 foundational modes you really need to wrap your head around: volume control and pressure control. In volume control, you're telling the machine, hey, deliver exactly this set tidal volume, say 500 cc's. The machine is going to push that exact volume, no matter what, which means the pressure in the airway is going to fluctuate depending on how stiff the patient's lungs are. But in pressure control, you tell the machine, do not exceed this preset peak pressure. So the ventilator pushes air until it hits that specific pressure limit, meaning the actual volume of air delivered is what varies from breath to breath. Grasping that one distinction is literally step 1 to mastering the vent.
All right, Section 4, Hemodynamics and Vasoactive Drugs.
So if the ventilator acts as the lungs of the ICU, vasoactive drips are absolutely the heart. And that brings us to a massive, bold number that you need to remember, 65 millimeters of mercury. This is your universal initial mean arterial pressure, or MAP, target. The evidence clearly shows that targeting a MAP of at least 65 ensures adequate organ perfusion in almost all shock states. It is the golden number you'll constantly be watching to make sure the brain and the kidneys are actually getting blood.
But what happens when that MAP drops below 65? Well, that's when we reach for our vasoactive drugs. But to use them right, you have to mentally categorize them into two main classes. Vasopressors induce vasoconstriction. Think of them as squeezing the pipes to get that MAP up. Inotropes, on the other hand, increase myocardial contractility. They squeeze the heart muscle itself to improve cardiac output. Now sure, the line sometimes blurs because some drugs do a little bit of both, but fundamentally knowing if your patient needs tighter pipes or a stronger pump changes absolutely everything about your management.
When you're choosing between these drugs, you really need a mental cheat sheet. Let's trace it out together. Phenylephrine is a pure alpha-1 agonist. It strictly vasoconstricts, boosting the MAP, but watch out because it can cause a reflex drop in the heart rate. Then you have norepinephrine. It has strong alpha-1 but also a little beta-1 activity, making it an absolute powerhouse for strong vasoconstriction while still supporting the heart. Finally, dobutamine acts on both beta-1 and beta-2 receptors. It's an inotrope that ramps up cardiac output. Connect the specific receptor to the clinical effect, and you won't be left guessing at the bedside.
And that brings us to our final part, Section 5, Surviving Sepsis and Shock.
Sepsis is without a doubt one of the most time-critical medical emergencies you're going to face in the ICU, and you literally have to act fast. According to the Surviving Sepsis campaign, there are strict, non-negotiable time targets. At the 1-hour mark from recognition, you must administer broad-spectrum antibiotic therapy. Don't wait. By the 3-hour mark, you need to be administering the initial IV fluid resuscitation. And by the 6-hour mark, you need to achieve early anatomical source control, meaning if there's an infected abscess, the surgeons need to be draining it by then.
Now, speaking of that 3-hour fluid window we just mentioned, here is another absolutely critical number to commit to memory: 30 milliliters per kilogram. For adults suffering from sepsis-induced hypoperfusion or full-blown septic shock, the guidelines strongly suggest giving at least 30 milliliters per kilogram of IV crystalloid. Of course, you'll need to closely monitor the patient as you go to avoid over-resuscitating them, but this is your definitive guideline-directed starting metric. And keep in mind, managing sepsis isn't just about dumping in fluids and giving antibiotics. It involves a few other really crucial care bundles. Step 1, utilize a restrictive blood transfusion strategy. We don't just hand out blood freely anymore, we wait for a specific threshold. Step 2, initiate insulin therapy if their glucose climbs over 180 milligrams per deciliter. See how that ties right back into our Fast Hugs glucose control. And step 3, use comprehensive medication reconciliation during transitions of care, ideally looping in a pharmacist, just to guarantee we aren't accidentally carrying over incorrect med doses.
So we've covered the ICU environment, those essential daily checklists, the mechanical ventilator, hemodynamics, and the basics of sepsis. The critical care environment is vast, no doubt about it, but with a structured toolkit, it is absolutely manageable. So I want to leave you with this final provocative question. How are you going to apply the Fast Hugs checklist on your very next ICU shift? Seriously, the next time you walk up to a bedside, don't just stare blankly at the monitor. Run through your checklist. Be systematic. Be thorough. Thank you so much for joining me for this explainer, and good luck out there on the units.